What a pleasure it is to be able to speak to you today on behalf of people who live with type 1 diabetes. And as you will discover, this has sort of been my passion and intense life journey to help them. And low carb really appears to have a major role. By way of disclosure, I will just first say that I've been a consultant for Lexicon Pharma for a drug that alters carbohydrate metabolism, for VertaHealth, for No Foods, and also for Sanofi Aventis as they commercialize this drug that alters carbohydrate metabolism. I want to talk to you about type 1 diabetes, and for a pediatrician such as myself, this was really the prototypic, feared, awful thing that could happen. So let's just imagine, in 1915, a pediatrician such as myself would have a mother bring a child into the clinic, and the child would be wasting away. And essentially, there was no therapy available. And the primary therapy was a diet that emphasized fat as the major macronutrient. And you could extend, this is a so-called Allen diet, and you could extend the lifespan of people from a few months to a few years. But essentially, they would eventually waste away. And with the discovery of insulin, children were able to live remarkably, wonderfully. And Banting and Bess won the Nobel Prize for this, and there were ticker tape parades, and it was considered at the time a cure for type 1 diabetes. Really an amazing thing. We're coming up on the 100th anniversary of this discovery. But was insulin really a cure for type 1? Unfortunately, the answer turns out to be no. And so in the initial years following the discovery of insulin, this is a clinic series from the Joslin in Boston. What you see is in the decades following the discovery of insulin, people began to be diagnosed with very serious complications of diabetes. And these are the ones that we all know and fear. And they include, as you can see here, calcified arteries and retinitis proliferans, that's diabetic retinopathy, high blood pressure and proteinuria, diabetic kidney disease. And it was quite serious. And moreover, these complications would ultimately result in altered survival. So insulin-treated type 1 diabetes patients had very high rates of mortality, even into the 1990s. So I'm 52, and I was born in 1965. I don't have type 1 diabetes, but if I did, I would have been in this cohort that was approximately the second cohort. And you can see, fast forward into my virtual diagnosis of type 1 diabetes, about a third of my peers would have expired from this. Really a serious problem. Okay, so what could we do about this? And anybody who thinks about type 1 diabetes has to understand the diabetes control complication trial, which really ushered in the modern era for type 1 diabetes care. It's a very simple, shockingly beautiful clinical trial. And what they did was they just asked, if you got people's blood sugar better, would they end up doing better? And so they got 1,441 patients, type 1 diabetes of only a few years duration, and they randomized them to either intensive therapy or conventional therapy. And the idea was to reduce their blood glucoses, and they measured this with glycated hemoglobin, which is a precursor of what we now know as hemoglobin A1C. And you can see that the cohort that got this intensive therapy had much lower blood glucoses. It was intended to be a 10-year trial. But there's a safety and monitoring board that's following the trial, and they see that there are these huge differences in between the curves in the primary outcome measure, which is microvascular complications, retinopathy, eye disease, and nephropathy, kidney disease. And they said, we have to stop the trial. So they stopped the trial. At the American Diabetes Association scientific sessions, they held press conferences. There was a big talk. And what happened? Well, again, you can see this amazing paper in the New England Journal that describes the immense difference in microvascular complications in between those who had this intensive therapy and those who had conventional therapy. What was intensive therapy? At the time, they basically just tried to figure it out. There really were no standards. It was an early form of crowdsourcing. So there were mandatory conference calls, and they told each center to basically share their best practices. And in some cases, people were very intensely followed. On average, people were contacted by phone call or face-to-face way more than once a month. Okay. And the cute part about this trial is it's now been 30 years, so we can follow this cohort and see what happens. And the follow-up study has been incredibly informative. And what you see is that the conventional arm, they began to have essentially slightly better outcomes. So they learned the benefits of intensive therapy, and they started managing their diabetes more aggressively, more injections per day, trying to get their blood sugars closer to normal. The people who were in the intensive arm, well, they lost the support that they had been provided by the NIH. And as a result, they went from an average glycated hemoglobin around 7.4 up to around 8. And that's where they've remained. But the really amazing part is that the effects of intensive diabetes control have lasted to this day. And so there's one, this is EDIC, and essentially this is the cardiovascular outcomes, and what you see is decreased cardiovascular disease with intensive type 1 diabetes treatment. That's really exciting because it says that everything that we do to support people who live with type 1 can have huge effects on their overall health. And it's not just cardiovascular disease, it's actually also survival. So wonderful, right? And it really puts the pressure on us to come up with a better way to treat and support these people. So millions of people have type 1 diabetes, 1.25 million Americans, and it's a big deal. So it's the most common life-threatening chronic illness of childhood in developed countries. So it's a really, really terrible scourge for our society. Growing in prevalence, all ethnic groups, injected insulin is the only available therapy, really, and a major risk of life-threatening complications. And moreover, definitive therapies have been a long ways off. And you'll notice I didn't use that C word. I try not to use the C word. It starts with a C and it includes an R. You can fill in the vowels. But I would say that for us who support people with type 1 diabetes, it's really important to be grounded in the here and now. Our country has made a huge commitment to support these patients, as evidenced by support from the federal government in the diabetes, special diabetes program. And as you can see here from this picture, even the President of the United States, our previous president, was on board with this. This is a picture that was taken on the south portico of the White House, and I was about 20 feet away with 200 kids with type 1 diabetes, and we were on a lobbying trip. So really an amazing fight to try to support them. So are we successful in caring for people with type 1? Generally, no. And this, I think, is the best data on glycemic outcomes for people with type 1 diabetes. And you can see the vast majority of people who live with type 1 diabetes are not able to achieve the ADA recommended targets, which is less than 7.5 for children and less than 7.0 HbA1c for adults. People just can't do it. It's too hard. And are there adverse consequences even if you do achieve your glycemic targets? There's a New England Journal article. It's pretty amazing. I don't really like to talk about negative stuff. I'm a relentlessly positive person. But this paper shows something very disturbing, and I want to highlight it for you. In patients with type 1 diabetes who are able to achieve outstanding glycemic control, hemoglobin A1Cs less than 7, they still have a risk of cardiovascular death that is 2.92-fold the general population. And death from any cause is 2.36. So that's scary, and it says we need to do better. And there's huge unmet need for this population. Okay, so parents always ask me this: when will basic science knowledge translate to improve type 1 diabetes outcomes? And what I tell them is it's a long and winding road, and I don't really know. And there's a bunch of potential ways that we could support and help people, and they include medicines that might affect beta cell regeneration of the cells that have been lost, stem cell therapies, or immunotherapies, poisoning the immune system to get it to sort of redirect itself and not destroy the beta cells. You'd still have to regrow the beta cells somehow. Or advanced technologies like an automated insulin delivery system. And as it turns out, it's just too complicated to have automated insulin delivery with a single hormone because we consume very large amounts of carbohydrates, and by the time the blood glucose goes up and the insulin goes in, there's just too much of a temporal delay, and so you end up swerving back and forth in glucoses. Very unsuccessful. My interest in low carb essentially came from a paper, and I'm not really going to talk about the paper, but we made a discovery starting about 10 years ago that people with type 1 diabetes have minimal attempt at beta cell regeneration. So within their pancreas, if you look at cell cycle entry and you're asking, is there any attempt to make new beta cells? You find no. So I was shocked by this, and it said to me that my role as a basic scientist might, at least in my lifetime, never translate to improved outcomes for people with type 1. And so I had to ask, what else could I do to try to affect change to support these people? So I want to talk to you about this idea of carbohydrate metabolism in type 1 and get into the pathophysiology. Insulin secretion by the beta cells really at the center of glucose homeostasis, as you know, and the islets make insulin, which act upon skeletal muscle and also act upon liver to suppress hepatic gluconeogenesis and also act upon fat to drive glucose into fat to support adipogenesis. And this is sort of how it's supposed to work in the normal state. But in type 1 diabetes, things are a little more complicated because you've lost your beta cells. You have a few beta cells, if any at all. You try to replace the beta cells with injected insulin. It's an incredibly crude and wildly difficult thing to do. And then let's imagine you are told to eat something like this. So what is this? Snackwell's cookies, fat-free, devil's food. So what happens here? So with Snackwell's cookies, you drive your glucose up very high. And as a result, you need a whole bunch of insulin because you're consuming a lot of carbohydrate. And then you're driving a huge amount of insulin ultimately to suppress hepatic gluconeogenesis and a huge amount of insulin to the fat. And people who consume a lot of carbohydrates end up gaining a lot of weight in type 1 diabetes.